Hello everyone, my name is Wakas Tariq. I am a physician associate working currently as a hospitalist. In the inpatient setting, we often take care of post-operative patients, particularly those that have undergone total hip or total knee arthroplasties. Venous thromboembolism or VTE, including DVTs and PEs, are a significant complication that can occur in this population post-op. Because of this, it is critically important to select a most appropriate strategy to prevent VTEs from occurring. Traditionally, direct oral anticoagulants have been widely used. However, aspirin in the recent years has been emerging as a simpler, more cost-effective alternative. This presentation will ask a very important clinical question. Can aspirin provide comparable efficacy and safety to direct oral anticoagulants in preventing VTEs following a total hip or a total knee arthroplasty? I report no financial conflicts of interest or external funding for this presentation. This presentation was completed as a requirement for the Doctor of Medical Science program at High Point University. Venous thromboembolisms, or VTE, is a significant complication that can occur following total hip or total knee arthroplasty procedures. It is associated with increased morbidity, prolonged hospital stays, and higher healthcare costs. Because of this, effective prophylaxis is essential, not only to improve patient outcomes, but also to reduce the overall strain it has on the healthcare system. While pharmacological prophylaxis is the standard of care, there is no clear consensus on the optimal agent, dosing, or duration. Multiple anticoagulants have been shown to be effective in reducing VTE risk, but on the flip side, they've also been shown to increase the risk of bleeding. It really comes down to finding something that works well and can prevent VTEs, but is also a safe option for patients. Because of this, aspirin has been getting more attention as a simpler, more affordable option. It raises the question again, can it work just as well as other blood thinners in preventing these clots? Aspirin has several potential advantages. It carries a lower risk of bleeding, it costs less, it's widely available, and it interacts with fewer medications. These advantages makes it a very attractive option, especially for certain patient populations. The purpose of this presentation, again, is to evaluate the efficacy and safety of aspirin as compared to direct oral anticoagulants or DOACs for the prevention of VTEs following a total hip or a total knee arthroplasty. A comprehensive literature search was conducted using PubMed and SynHall, focusing on studies published over the last 8 years. The search yielded 362 articles from PubMed and 133 from SynHall. These articles were then screened and selected based on predefined inclusion and exclusion criteria to ensure relevancy and quality. A total of 5 clinical studies were found and included in this narrative review for qualitative synthesis, comprising of 3 randomized controlled trials and 2 observational cohort studies. The first study that we'll discuss that looks at aspirin as compared to DOACs is a study by Anderson and his team called the EPCAT-2 trial. It's a multi-center double-blinded study of over 3,400 patients. After 5 days of rivaroxaban, patients were randomized into receiving aspirin as VTE prophylaxis versus the other group that would be continued on rivaroxaban. The study concluded that VTE rates were similar in both groups, and it showed aspirin to be non-inferior to rivaroxaban. However, there's a key limitation in the study where all patients received rivaroxaban initially. This confounds aspirin's true efficacy, especially if used as monotherapy in the immediate postoperative period. This next study by Wren and his team, they conducted a randomized controlled trial of 70 total hip arthroplasty patients, comparing aspirin and rivaroxaban. It concluded that the VTE rates were similar between aspirin and rivaroxaban, showing that aspirin was non-inferior to rivaroxaban, although the study is limited by its small sample size, which may affect generalizability. This next study is a small randomized controlled trial that evaluated aspirin as compared to, again, rivaroxaban in total knee arthroplasty patients. It showed that there were no VTE events that occurred in either group, and only minor bleeding was reported. It does show a trend towards less bleeding in the aspirin group, but not very significant. The study concluded that aspirin showed similar efficacy and safety as compared to rivaroxaban. But again, the study was limited by its small sample size. This next study is a large observational study analyzing over 218,000 patients using data from the National Joint Registry, comparing aspirin with DOACs. The study found that DOACs were associated with slightly but statistically significant lower VTE rates than aspirin in both total hip and knee arthroplasties. Major bleeding rates were similar between the two groups, no significant difference. The findings are limited by its observational design. This final study is again a large observational study comparing aspirin with apixaban, this time in hip and knee arthroplasty patients with a 30-day follow-up. VTE rates were slightly higher with aspirin, but not significant. No major bleeding occurred in either group, although wound leakage was slightly more common with apixaban. Again, the findings are limited by the study's observational design. This table here just summarizes each study's design, the population, key safety, and efficacy findings. While interpreting these studies, there are some other factors that should be considered. Firstly, aspirin dosing varied across all studies and trials, ranging from 81 milligrams to 325 milligrams once or twice daily. The optimal regimen still remains unclear. Additionally, most comparisons involved rivaroxaban rather than any other DOAC. This limits the generalizability of these findings to the broader class of direct oral anticoagulants. Overall, the evidence does suggest that aspirin is an effective and safe option for VTE prophylaxis, demonstrating non-inferiority in efficacy and safety as compared to DOACs. It is an especially good choice for patients who are of lower economic or social status, as it is very cost-effective and widely available. However, given the limitations of these recent studies, further research is still needed to establish standardized dosing and treatment recommendations. These are the references that guided this presentation. I would like to sincerely thank you all for your time and attention. I hope this presentation was informative and met your expectations. Thank you again.